Okay, yes, Dr. Quang. We are almost to start our webinar today. In the very beginning. Okay. Hello. Good morning and good evening to all my lovely audience of ICC and all the participants here. I am Dr. P.Y. Cho. Today, I'll moderate the webinar with my colleague, Dr. Junior Tu, together for this webinar. Today, we are so happy to invite Dr. Quang to give us the lecture in ICC. Dr. Quang, the current is working in the Institute of the National Hospital of Odontostomatology in Hanoi. Dr. Quang's education is receiving the DDS degree from Hanoi Medical University in 2011, and he received a master's degree in oral and maxillofacial surgery from the University of Manchester, UK in 2015. And furthermore, Dr. Quang received a PhD degree in medical research from Shimen University, Japan in 2021. And he finished his clinical fellowship in oral and maxillofacial surgery from Shimen University, Japan, from the big professor, Dr. Kano, and from the 2016 to 2021. And he spent 1 year in the oral and the maxillofacial surgery fellowship in AZ Xinjiang, the hospital, Bruges, Belgium in 2023. The currently professors, the Quang's the working position is one of the attending surgeons in Department of Plastic and Aesthetic Surgery at the National Hospital of Odontostomatology in Hanoi. And today we are so happy to invite four very well-known panelists to come to give us a valuable comment. The first one is Professor Ellen Ko. Professor Ko working in Chang Memorial Hospital, Taiwan. The second one is the Professor Susana Heredero, and her working is at the hospital Cruz Roja de Cordoba at Spain. And the third one is the OMFA surgeon, Dr. Narisapong Chaprakit, and her working in the Thammasat University at Thailand. And she is one of the member of AOCM representative. The fourth one is the Dr. Tan Mei Hui, and her working place at the Chang General Hospital at the Singapore. So can wait to learn from Dr. Quang about his topic today. So Dr. Quang, please.
Oh, hello everyone. Hello everyone. My name is Quang, and I'm from Vietnam. We had a short chat with the other panelists, and it looks like that I am the youngest one, and I'm the most inexperienced one here. So I have to repeat that it is a great honor for me to be invited to speak in the ICC forum. Yeah, so first of all, I need to thank all the panelists, thank the host, and thank all the attendees for listening to my talk. Thank you very much. So can I share my screen now?
Yes, please.
Okay. Okay. So let me start. So the topic today I want to share with you is the application of open source software in complex maxillofacial surgery. And I am a maxillofacial surgeon. And for the beginning, so my first exposure from since 2016 to 2021, I was clinical fellow and also a PhD student in Shimane University in Japan under the supervision of Professor Takahiro Kano. And it was a very long story because in Vietnam, we have no residency program and no formal training program in maxillofacial surgery. So at that time, I need to send emails to every country in the world, not every, but a lot of countries in the world look for the training. And and unfortunately, Professor Kano in Japan accepted me to be a fellow, and he promised me that I can do surgery, and he could teach me a lot of things in maxillary surgery. So that's the reason why I went to Japan for more than 4 years, and I did the training. I mean, the surgical training, and also the PhD degree. So here, so on the top is a picture of Professor Kano, and I think some of you may know him because he has been to Taiwan a few times. And on his left is me. At that time, I wear glasses. And my other fellow, my two Chinese friends on his right, and other Japanese, my other Japanese friends on my left. And on the bottom is a picture that I was operating an orthodontic surgery case. Okay, during my time in Japan, I wrote a few papers, and my last paper in Japan was a paper about virtual surgical planning. It was quite a simple case. The case was a recurrent ameloblastoma, and Professor Kano decided to do the marginal mandibulectomy, and with the assistance of the cutting guide and the patient-specific implant, because after cutting a part of the mandible, I mean the tumor, the border, the rest of the body was only 5 millimeter. So it means biomechanically it was too weak, so it couldn't support the rest of the mandible. So that's why he needed the reconstruction plate to reinforce the mandible, and it was. He told me that it was one of the first cases in Japan. I'm not sure about that because last year was 2020. And if you look at the literature since 2014, there was a lot of papers about virtual planning and BSI or something since 2014. But at that time, it was 2020. And he said that, Professor Kano said that in 2020, the insurance company approved that they will cover the fee for PSI and virtual planning. Anyway, so he asked me to write the paper. And when I was in Japan, I did some surgery, and I assisted in as own kind of surgery because Shimane Prefecture of Shimane province was a countryside, so they didn't have a lot of hospitals. So they did everything in the field of maxillary surgery, including orthodontic surgery, pan-facial trauma, and cancer. So I was lucky to involve in all of the surgery. But I personally didn't think about virtual planning because at that time I thought that it was very expensive. It was it cost a lot of money. And I asked Professor Kano that, okay, how much do you pay for this case? Oh, I didn't. So he said, I didn't pay. I don't pay. The insurance company pay, but the fee is around $7,000 US. So at that time, I think, or maybe $7,000 is acceptable in Japan or in other developed countries. But for this kind of surgery in Vietnam, it's only maybe $1,000 or $2,000. And now I need to tell the patient that you need to pay another $7,000 US for that. It's not really realistic. So I always so at that time I thought about myself. Okay, I came back to Vietnam and I did some advanced. Maybe I did some advanced surgery, but in the conventional or traditional way. Anyway, he gave me Professor Kano gave me the opportunity to write the paper, and because I wrote the paper, I needed to read a lot. I need to read a lot in the literature, and I found this one. And I found this paper, and this paper, the name of the paper is Low-Cost Design Manufacturing Surgical Guide and something. And in this paper, the author used a software named Blender. Maybe some of you have known the software. Blender is a 3D software an open source software, and it's totally free. And a lot of surgeons have been using it for virtual planning and surgical guide. So since the time I read this paper, then and it like a milestone, it changed my career. I mean, dramatically, and since that time, I focused all of my time on virtual planning, on all of the 3D thing, and because of that paper, because of the open source software. So in this paper, the author did the tumor resection, and after that, the fibular flap with the help of the surgical guide designed by open source software, and it's totally free. And I read some other paper. The cost of the surgical guide is only 4 or 5 US dollar. So it's really acceptable and really realistic in the Vietnamese context. So it changed my life forever. Anyway, after that, I explored YouTube and I found Dr. Logan Gandry. I think maybe you know them. Maybe you know them because I saw him. He was a panelist last week in the IMC, the International Microsurgery Club. I think so. I think maybe some of you know him. He's a maxillary surgeon. He specialized in microsurgery, and he did some video of how to use Blender how to use Blender to make the to design the surgical guide and on YouTube. And I follow his YouTube video, the third one from the left. I follow that one, and I follow step by step. And in 2 months, in 2 months I could do everything he did on the video with some modification, of course. And at the beginning of 2021, I designed the first surgical guide for the first case of cancer resection. Not cancer. The amyloblastoma resection and fibular flap. The first one in my hospital at the beginning of 2021. Thank for Dr. Lauren Gandry. I had the chance to meet him the first time in Canada last year during the Congress of the International Association of Oral and Maxillofacial Surgery. And so after the initial success, of course, is the spleen, the surgical guide I designed at that time was not really sophisticated, but anyway, we can call it the initial success. And after that, I thought maybe we can use Blender for dental implant. Maybe we can use this for orthodontic surgery. And maybe someone is kind enough to share it on YouTube. And so I searched again on Google and YouTube, and I found this one. And Mr. Cicero Moraes, he's a 3D designer specialized in forensic facial reconstruction. And he was a genius. He is a genius, and he wrote during his free time. He wrote a software. It's a modification of Blender, and he named it Autalk on Blender. It's a Portuguese name, and the Autalk on Blender specialize in using Blender to plan orthodontic surgery, and it's even more powerful than that. And Mr. Moraes is also a very famous guy. He has appeared on newspaper a lot of time. He often do the reconstruction of the face of the ancient skull. And his most recent work is to reconstruct the face of Johann Sebastian Bach. I think you know Johann Sebastian Bach. He's a famous composer from Germany. And after that, I use and since then I use Autalk Blender on everything. Okay, some of my application, of course, the first one is the tumor resection and fibular reconstruction, but now I don't do it anymore. I taught how to do it to my younger junior plastic surgeon in my department, and now he specialized in making surgical guide for tumor resection and fibular flap. I also use Blender for other things like trauma. Here you can see an example of an orbital trauma. We don't need any expensive software here. We just use Blender and use a very simple command, and it's a mirroring of the intake orbit to the opposite side, and then we can use this to manually bend the orbital mesh. And this case is another case for the late trauma reconstruction. Here I use a drilling guide and the positioning guide to help me to reconstruct the zygoma. For this patient, we have no landmark. Normally for the zygoma fracture, we have the landmark to help her to orientate the segments. However, for this one, we have some fracture of the cranial bone here. So that's why we have no landmark. And so in the software, I need to manually move the bone segment into the reasonable position. And after that, I use the software to design the positioning guide and the drilling guide to help me during the surgery. Yeah, it's quite similar to orthodontic surgery. And of course, I use it for orthodontic surgery. Of course, I plan the cutting line, and then I plan the movement, and I also design the cutting guide. Here is a cutting guide on the bottom left of the picture. The cutting guide, of course, I think if you are familiar with cutting guide, there's nothing new here. What I'm trying to say is, the software is free. If you use ProPlan, if you use the Dolphin or other similar software, or even the IPSK designer, you have to pay a few thousand US$ every year, maybe 10,000 US$, because they 10,000 US$ every year. And it's for example, for IPS from KOS Martin, it only allow you to design the surgical splint. There's no option for you to design the cutting guide or the PSI. No option at all. And for ProPlan, yeah, for 14,000 US$, because someone from Malaysia, they contacted me and they tried to sell me the program, the software to me, and they said that, okay, you need to buy it with 14,000 US$. But if you want to design cutting guide and PSI, you are more than welcome, but you need to pay another 4,000 US$. Reasonably, yeah, I consider it. Anyway, for this software, I not only the splint, you can design the cutting guide, you can design the PSI, or actually, you can design everything you can imagine. It depends on your skill. It depends on your 3D designing skill. Of course, I'm not a 3D designer. Maybe I'm just a good user of or talk on Blender, good in terms of surgical perspective. I'm a good user of this software. Anyway, here, so I will come to some case report to show you some of my application. Oh, the first one. This is 29 years old male. He has a traumatic brain injury, and the neurosurgeon had to remove part of the skull for the decompression. And he also had the fracture of the zygoma, of the left zygoma. But in the emergency situation, they didn't care about that. They try to save the patient's life, and they ignore the facial trauma. And after that, the patient came to me, and he wanted me to correct the zygoma fracture. And he told me that some other doctor refer the patient to my hospital in order to have the zygoma fixed. After we fix the zygoma, the patient will come back to the other hospital and to do the cranioplasty. And at that time, I thought, Why do we need to do that? We have the bicoronal incision, and when we do the zygoma, when we try to fix the zygomatic fracture, we use a bicoronal approach, and when you do the cranioplasty, we also use a bicoronal approach. So why don't we do it at the same time? I have read some papers that they normally in the world, in some standard hospitals, they do it. So why in Vietnam, why in this city we have to separate the surgery into two? Anyway, so I talked with my head of department. I talked with my the head of the hospital to, in order to do the cranioplasty and the zygomatic fracture at the same time, and the reason I have to tell you that why I need to talk to my head of department, because my hospital is the dental hospital. In the introduction, you see that my hospital is the name of my hospital is a hospital of odonto and stomatology. It means dentistry. So my hospital is a hospital of dentistry. So we focus mainly from this side, from the orbit downward, and we have never done any cranioplasty before. So that's why it was the first case. Maybe it's very normal to you, but for us, it was the first case in 2021. Oh, so we so here on the CT scan and the MRI, you see the defect of the cranial bone, and you also see some the zygomatic fracture, and you saw because of the orbital trauma or the orbital floor fracture, the eye was there a sagging with the eye. It's not in the normal position, but unfortunately for the patient and fortunately for the doctor, that there's no visual acuity on the left eye. So it means that we don't need to worry about that. We can correct the eye, but we even if we make some mistakes, there's no problem at all. Yeah. Here the reconstruction, the 3D reconstruction of the skull before the surgery. Yeah, of course you can see what I have already told you. There's a defect in the cranial bone and also the zygomatic fracture. Yeah, and the orbital fracture as well. So my initial plan was to correct the zygoma and do the cranioplasty and do the orbital reconstruction. I have to say again that it is a virtual plan. It's a virtual plan. It's a little bit different from the real plan, because in the virtual plan, I need to correct the zygoma first, because the defect of the cranial bone is not the real defect. Then after we reposition the segment of the zygoma, now after the correction, we have the real size of the defect here. Now in the software, I cut the zygoma into different parts, and after that I manually reposition it into the reasonable position here. Okay, I hope you can see the video. Yeah, it is not the initial position, it's just the reasonable position that I think that is reasonable. Anyway, after that I send the scale, the corrected scale, to the PIC company, to the 3D printing company, and they produce the PIC implant based on the true size of the cranial defect. Initially, I sent the initial scale, the initial scale to the company, and they had no idea about the zygomatic fracture, and they made the very beautiful cranial implant. However, I said that no, it's wrong, so it's not correct at all. So after that, I needed to correct the zygoma first, and then I sent the corrected scale to the company, and then I made the implant. So after that, we have a multidisciplinary consultation with the neurosurgeon. And like I said, the panelist, one of the panelists, Dr. Susanna, she's very lucky because she has the neurosurgeon as her husband. So I am very lucky too, because my classmate, my very close friend, he is also a neurosurgeon, and he's working in a hospital besides my hospital. So I called him, okay, come here. I need you to do the cranioplasty for me, and then I do the zygomatic reconstruction. And for the neurosurgeon, for cranioplasty is a piece of cake for them. They do it every day. They do it every day, and the most in the, I mean, the special thing about this case is that it is the first time we cooperate between the maxillary surgeon and the neurosurgeon. It's the first time in my hospital, at least in my hospital. When I and because it was the first time, so we didn't know how to calculate the money that the patient had to pay. So I asked my head nurse to ask other hospital that how much do you collect for, how much money do you collect for cranioplasty. And my head nurse asked other head nurse in other hospital, and the other head nurse said that, why don't you separate the surgery? Why don't you do the cranioplasty first, and after that you do the zygoma reconstruction? So well, so so it really means something. It really means that in their mindset, the cooperation has never happened before. So I was a little bit surprised. And anyway, we cooperate with the neurosurgeon. First, we'll make the incision. The incision include the previous scar, and they added some other incision, and they call it the Mercedes incision. Yeah, they call it Mercedes incision. And I also use a subtarsal incision and some the upper vestibule incision. Okay. First, here first, the neurosurgeon input place the cranial implant. So what we need to differentiate here, in the virtual plan, I reconstruct the zygoma first. But here in the real surgery, my neurosurgeon input the cranial implant first. And the cranial implant, it didn't have the regular border. The border of the cranial implant is irregular. Irregularity here means it can serve two functions. The first one is the implant to cover the brain. The second function is to act as a surgical guide, because so my neurosurgeon insert the implant here, and you can see in this point, the implant can serve as a surgical guide for the zygoma segments here. Yeah, and after that we fix everything with mini plates, and we also do the orbital reconstruction with mirroring technique here. Nothing special about it. Okay, so it's after 2 weeks. After 2 weeks of hospitalization, there's no problem with the patient. The healing was very well. There's no infection. Everything looks okay, and it's very normal. Okay, very normal. No problem at all, at least in my eyes. And 2 months post-op, yeah, of course it's not perfect, but it looks beautiful to me, and I was very proud of it anyway. But however, 3 months post-op, it's not beautiful anymore. Okay, there's something that I think you may notice, temporal hollowing. So there's a hollow on the temporal area of the patient, but at least we can appreciate that we have the very nice curvature of the scalp. So, but but the temporal here, the temporal area is still not really aesthetically sufficient. So, well, at that time, it was my first cranioplasty case. So I didn't know about temporal hollowing. So after I saw this, I searched on the literature and I and I knew that okay, temporal hollowing was quite common complication, and and I didn't calculate the temporal hollowing. So I needed to learn from this experience. Okay, so we come to the second case. So I learned from the first case, and then I can do the second case. So for the second case, we have a similar medical history of this man. He has traumatic brain injury. He also had the zygomatic fracture, and the difference here, his skull has been reconstructed in another hospital, but they still ignore the zygomatic fracture. However, the cranial defect and the zygomatic fracture is they are separated. They are not really related to each other. However, the patient still complain about the asymmetry of the skull and also about the cheek. So he knew that I have done some cranioplasty and I can do some zygomatic fracture. So he came to me. Okay, he has similar information, the deformed left zygoma and lack of the contour in the temporal area. Luckily, he didn't have the maxillary fractures and no problem with the mouth opening, and the occlusion was okay. And here are the reconstruction of the 3D reconstruction of the patient. So the first thing, he had the zygomatic fracture. No, it's something very minor and very simple. Everyone can fix it. However, regarding the cranioplasty, the cranial implant, someone in the previous hospital, I think he did a very good job in to reconstruct the skull, to reconstruct the defect. So they didn't have the 3D software, they didn't have any advanced tool, but they did a very good job. And at that time I didn't think that I can do anything better if I use the same method. I use the same way. I did the same way with the first patient that I showed you. But however, they made the same mistake that I have already made. They didn't think about the temporal hollowing. So my plan is I will replace the titanium mesh with the PIC implant with the temporal bunch. The temporal bunch, I decided to compensate for the soft tissue volumetric loss. And I will also correct the zygoma, of course. Okay, how did I do it? I use another software for segmentation. And the name of the software was ITK Snap. The function of ITK Snap was first to visualize the CT scan, and secondly, it can help you to do the segmentation. The segmentation, for someone who don't know what is segmentation. Segmentation is to selectively extract the information from the CT scan. For example, here I needed to extract the bone tissue, and I also extracted the temporalis muscle. So for this guy, I did the segmentation for the right temporalis muscle, and after that I used the mirroring technique. I mirrored the right temporalis to the left side, and I use the mirrored right temporalis to help me to design the cranial implant. Yeah, so on the picture on the right side, you can see the pink object. The pink object, it's the implant design. So I try to make it bigger I try to make the implant bigger to include the mirrored right temporalis. Okay. So here's a picture of the design. The left side, the titanium implant. The left side, the titanium implant, and the right side is the big implant that I designed. Okay, a picture from the above. I hope that you can appreciate that I have made it bigger to include the temporal muscle. Okay, the surgery. There's no problem with the surgery. My friend, my neurosurgeon friend, removed the titanium mesh, and after that we replaced the titanium mesh with the big implant. And because I have already compensated for the temporalis muscle, so I removed the patient's real temporalis muscle, because if I didn't do it, then the soft tissue on the left side will be too big. Okay, here's the result: 3 months post-op. Okay, so I waited for 3 months. It looks better, I think. Not perfect, of course, but it looks better than the first one, I think. Yeah, 3 months post-op. I corrected the zygoma as well. After that, I tried to contact him, but he never answered my message and never answered my call anymore. Anyway, so I'm so sorry. I don't have the 6 month or the 1 year post-op picture for this one. But I think the idea is better. At that time, I thought, wow, in the literature I searched that they use the suspension of the temporalis. They use autogenous bone graft to compensate for the loss of the soft tissue here. So I didn't find enough paper. So I thought, oh my God, I was the first one to do it. However, after I did a proper search, I found that Stryker, the Stryker company, they made the same design a few years before. So I wasn't the first one. Okay. So now, anyway, so we finished about cranioplasty and we moved to the case report number 3. It is an orthodontic case. So we have the female 21 years old. She complained about gummy smile and the retruded chin. So she has a classic long face growth pattern, and I sent her for polysomnography, and we detected the obstructive sleep apnea. So the problem with her is she has a very high and narrow upper arch, severe mandibular protrusion, and proclived lower front teeth. So it's very typical for the long face growth pattern with gummy smile and retruded mandible. It's a classic class 2 malocclusion. So we have a severe incisor display of 9 millimeter and gummy smile 8 millimeter. Okay, so when I took the picture, initially I operated this guy 2 weeks ago. Anyway, initially when I took the picture of orthodontic patient, I often focused from the neck to the from the neck to the top. However, last month, Dr. Stanley Liu, he's a professor. I think you know him. He's also Taiwanese. He came to Vietnam and he gave a lecture about sleep apnea. And during his lecture, he mentioned that he showed some picture of his patient that when the patient has sleep apnea, and the patient often lean the head forward for to breathe easily. So since the lecture, I tried to take the picture of the patient from the shoulder because in this patient I noticed that she was leaning the head forward. So at that time I suspected the patient had the sleep apnea. although she was very young and she was very slim. And I talked with the family, I talked with the patient, and so I sent the patient the to my friend in the to my pulmonologist to do the polysomnography, and the result turned out that she had moderate sleep apnea. So I talked to the patient because she had sleep apnea. So she had so there's an indication for surgery first. So we shouldn't wait for the orthodontic treatment. So we had we had better doing the surgery immediately instead of waiting for 1 or 2 years of pre-surgical orthodontics. One of the most difficult thing for this patient is because, you know, when we do orthodontic surgery, we have to look for the natural head position. So in this patient, we don't have the natural head position of this patient is wrong, because the patient is leaning the head forward for better breathing. So I need to correct the posture of the head. So I asked the patient to try to stand in the more upright position. And to be very honest with you, I am not sure that if it is really the true natural head position. So I just think that, okay, I try to correct the head of the patient in the most reasonable posture that I think it should be. So there's no scientific method for that. I just do it by my hand manually. And I use a picture on the right side as a reference for my virtual planning. Okay, so it's a 3D reconstruction. You can see that the classic classroom malocclusion with a very retreated mandible. So my plan is my surgical plan for this patient is to extract the lower premolar, and after that I do the subapical osteotomy I try to recline the upper recline the lower teeth. Do instead of doing it orthodontically, I did it surgically, because we had a paper from the University of Hong Kong published at the beginning of this year or last year. I don't remember exactly. They did the same thing. They use subapical osteotomy to decompensate the lower front teeth surgically for sleep apnea, because after we decompensated it, we have more room for the mandible to move forward. So for the maxilla, I did the counterclockwise rotation, and I did the three-piece for one osteotomy only for the occlusion, and I also try to expand the width of the maxilla a little bit. Okay, here's the plan. Here's the plan. I try to move the mandible maybe 18 millimeter forward. So you can see the chain from you can see the chain of the chin from the retruded position to the forward position. Okay, I attach a video here. Yeah, here's my plan. Okay, for the designing part, I designed the level 1 cutting guide, and I also designed the subapical cutting guide. And after that, I also designed the positioning guide. So it was the first time 2 weeks ago I used a positioning guide for the guide for the subapical osteotomy. The reason and I found that it was very beneficial. Before this case, I only use the cutting guide and the positioning guide for the level 1 osteotomy, because all of you have already known the benefit of using PSI. However, I was too lazy to design the guide and the positioning guide for the subapical. But this time I used it, and I found that it was very beneficial. First, it saved me a lot of time. In any case of of subapical osteotomy for the class 2, it took me a lot of time to trim the lower border of the subapical segment. It took me a lot of time. For this guy, I use a cutting guide. I just made the 2 cut, and I didn't have to trim anything. The secondly is accuracy. Without the positioning guide, of course we can put the lower front teeth into the spleen. However, it can be inaccurate, because sometimes the teeth fit in the teeth, the upper part, the inside the edge of the teeth can fit into the spleen. However, the lower edge can rotate a little bit, and you never know that which one is accurate. But for this case, I use the positioning guide on the lower, and I use the spleen on the upper, and we have two measures to control the position of the subapical segment. So I found it very beneficial. So since this case, I do every subapical case with cutting guide and positioning guide. Okay. By the sagittal split osteotomy, I use the thicker plate, the thicker plate to have to maintain the position to prevent the relapse. The 3-piece level 1 osteotomy, nothing special. Use a cutting guide, and after that I use a positioning guide. And there's something different here. And there's something different. The cutting guide was printed when I was in Belgium last year. They also use a cutting guide, but the cutting guide was made by polymer, by resin. But here, I print the cutting guide by metal. The reason I do it, because we have a dental laboratory. They invested in the metal printing machine, so that's why I asked them to print the cutting guide and the positioning guide for me. And the price, you know what, is only $70. For the similar case, it may cost you $7,000 or even $10,000 for one case. But I use this one. I print this one for only $70 US dollar for this one. And that's the reason why I use convention after I inserted the positioning guide. I use a conventional plate here, and after I fix the conventional plate on the lateral buttresses, I remove one in the medial buttress, and I replace it with the conventional plate. And after that, I remove another one here, and I replace it with a conventional plate. So it's not PSI. It's not patient-specific implant. It's only positioning guide. Of course, the function is the same. However, the function is the same, but I have to remove it at the end of the surgery. I cannot keep it in the patient body. So it's my method to use the advantage of patient-specific implant, but I can also reduce the cost. And this setup only cost me $70. Okay. So, and I asked my professor in Belgium that why didn't you print it in metal? It give you more accuracy. Resin maybe it's not really accurate. So he said that the problem is the cost. We couldn't print it in metal because it's too expensive here. Okay. Okay, I changed to conventional plate like I told you here. I changed the positioning guide to the conventional plate here, conventional plate in the level 1. Okay, 10-day post-op. Of course, tomorrow she will come to me for the 2-week post-op. So now I operated her only nearly 2 weeks ago. So I only have the 10-day post-op, and luckily, for some reason I don't know why, see the swelling reduced very quickly. So because I was lucky, it's not because of my technique. Normally my patient often have this level of swelling after 1 month, but for some reason this patient have this reduced swelling only after 10 days. Yeah. Here's a picture. It's the profile picture, and you can see that the chin, although we still have a lot of swelling, but the chin have been moved forward, and the posture of the patient also changed. I didn't ask her to sit in the upright position, but luckily now it is her current natural head position. Okay, so now we come to the case report number 4. So this is a cleft patient. So this is female, 20 years old, multiple cleft related surgery, and the diagnosis is nasal maxillary hypoplasia. So she has the problem is she has a hypoplasia of nasal maxillary complex. Not normally in Vietnam, when we do the orthodontic surgery for this kind of patient, we often do the level 1 osteotomy to move the maxilla forward, and then the sagittal split to move the mandible backward. But for this patient, she has the retrusion of the nasal maxillary complex, and if we do the level 1 osteotomy, in my opinion, we will make the retrusion of the nasal area even worse. That's what I thought. So I needed to consult with some of my professor, and they told me that you need to do level 2 osteotomy. Okay, I have never done level 2 osteotomy before. I know that in Chang you have a very big craniofacial center, and you can do it very easily. But for me, it was the first time I did level 2 osteotomy, and I don't know anyone in my country who can do level 2 osteotomy. But anyway, I have the virtual planning software. I have the virtual planning tool to help me to do this case. And so I decided to do the combined level 2, level 1, and the sagittal split osteotomy for this patient. As you can see on the slide here, I tried to do the first I thought about doing the level 2 for this complex, for the nasal maxillary complex. After that, I wanted to rotate counterclockwise the complex. But if I did it, I will create the anterior open bite. So I think about doing the level 1 osteotomy with the level 2 to correct the open bite. And after that, I plan to do the sagittal split to finalize the occlusion for the patient. The reason I do it, because the reason I thought about it, because in 2019, I went to Hong Kong for the congress, and during for the surgery first workshop in Hong Kong in 2019. And at that time, I saw a case of Wang Shudong professor Professor Wang Shudong from Shanghai, and he did a complex orthodontic surgery case with level 3, level 2, and level 1 at the same time. So because of that, I thought, okay, it's very realistic that we can do level 2 and level 1 at the same time. So I came up with this plan. Okay, but how could I do the level 2? Okay, for level 2 osteotomy, a little bit similar to the level 2 fracture. So we need to make a cut. We need to make one cut in the nasal frontal area, the nasal frontal suture, and we have to make the bilateral cut of the medial wall of the orbit, and we have to make in the lateral buttress. Okay, I studied in Japan with Professor Kano, and in Japan they play baseball. They play baseball a lot. So Professor Kano have a lot of case of orbital trauma and a lot of medial wall fracture and the orbital floor fracture. So I am very familiar with the anatomy of the orbital wall and the medial wall. So for me, approaching the medial wall is not a problem, and approaching of the lateral buttress is not a problem, and and to open the bicoronal approach is also not a problem, because in Vietnam we travel by motorbike a lot. So I have a lot of pan-facial trauma case. So I have to do bicoronal approach a few times a month. So it's not a problem for me. The only problem that I think that I will have is the nasal frontal suture. How do I cut it without damaging the brain? I don't know anything about neurosurgery. So if I tear the dural matter, I need to call my friend. So, but I have the virtual planning software. So I design the cutting guide, the cutting guide on the right side. If you look closely, the cutting guide is aiming downward. Is aiming downward to avoid the skull base. So I follow them. So I design the guide, and I follow the guide to avoid the skull base. After avoiding the skull base, there will be no other problem. So here is a cutting guide for the level 1 osteotomy, and we have the positioning guide for the level 2 and the level 1 as well. Okay, now we have the surgery. During surgery, I did the level 1 first because I have cutting guide and the positioning guide, so I did it first. And then I opened the bicoronal approach, and I use a cutting guide and the cutting guide for the nasal frontal suture here, and for the osteotomy of the orbit, I just use a pencil. To draw the line of the osteotomy. That if you look closely, you can see some black lines here. That is, so it was the pencil lines that I used during the surgery to cut the bone. Okay, so after cutting it, I did a fixation, and replacing the positioning guide with the conventional plates. Okay, post-op. Okay, 6 months post-op. Is a frontal view, and it is the profile view. Okay, it looks better. It's not perfect, but it looks better in my opinion. Okay, what do you think? Okay, so for the conclusion, so using the open source software is safe, effective, and very accurate. There has been some paper they compare. There's some paper, I don't know the name. I don't remember the name of the paper. They compare the use of Blender and other open source software with some commercial software. So the accuracy is the same. So if you use it, you don't need to worry about the accuracy of the open source software. And for me, for my context, it's inexpensive. It's very cheap. Like I told you, it doesn't cost much. And because it's very cheap in Vietnam, I'm not sure in Taiwan or in other country, but at least in Vietnam, I'm still using it, and it's very cheap. And because it's cheap, it's benefit for the patient and doctor. Of course, it's cheap, so a lot of patients can use the same method. A lot of patients can be benefit from the modern technology in surgery. And one more thing, if the company makes the software or the service is too expensive, it means less patient can accept this modern technology, and less patient can approach, mean less doctor, less surgeon can have enough experience in using virtual planning. So if we can, so using the open source software offer a very cheap and very modern, very advanced technology and technology advanced option for both the patients and the healthcare providers, in my opinion. Okay, thank you.
Thank you so much, Professor Quang, for this amazing talk, and also congratulations on your excellent results. So at this time, I'd like to invite our panelists for some comments. So first, I'd like to invite Professor Ko.
Thank you. And thank you for Professor Quang for your excellent presentation.
I'm not a professor.
Your Dr. Quang for your excellent cases. And you use Blender 3D to apply in complicated craniofacial reconstruction, even a complicated orthodontic surgery. But in Taiwan, we didn't really use this free software to do the apply in the clinic, because we have a law. We need to regulate by Ministry of Health and Welfare about our software use. So every software, if we are going to apply to clinic use, and we need to pass the TFDA. And so far in Taiwan, we are commonly use the Dolphin 3D and the ProPlan and some other software that's being applied by a TFDA. But I don't know that if this Blender 3D can you generate some of the cephalometric measurements on this software? Because for orthodontic surgery, when we design the surgery, we really rely on the cephalometric analysis. Do you want to comment about that?
Yes, of course, we can. There's some option. If you, I mean, there are some function in the modified version of Blender that I'm using. It offers some analysis, as a cephalometric analysis. Yes.
Customize.
Yes, of course.
Customize. Customize. Oh, okay.
Yes, of course. Yeah, it does provide the option for the analysis. Yes. And I totally understand what you said about the regulation, because well, when I was in Japan, after I designed the cutting guide for the mandible and the fibula, I told my professor that okay, you don't need to pay the money for the provider. I can make it for you for free. You just need to print it. But he said that the Japanese Ministry of Health regulated, and you need to use a software which was approved by the Ministry of Health. Okay, fine.
Okay. Is the accuracy of 3D Blender being validated? As you, in your conclusion, you say that it is accurate, but is it accurate for clinical use?
I think it's accurate. I think it's accurate because there's some study about that. But I mean, if you ask me if I have already validated it myself, I haven't done any study to confirm that. The study I read, it was about using Blender. They compare using Blender and the commercial software in doing the mandibular resection and the reconstruction. It's not really for orthodontic surgery, I have to say. Yeah, so then I don't think there has been any software about using Blender, about comparing the planning and the final result using Blender in orthodontic surgery. I am doing it because we have collected a lot of data, because we have around 90 cases of orthodontic surgery every year, every year, and all of the patients, we use Blender for all of the patients. So I will collect the data and I publish it, and I will tell you later.
Congratulations. Thank you.
Okay, thank you, Professor Ko. Next, I'd like to invite Professor Hidero.
Hello, I'm not a professor too, so because Susanna or Dr. Hidero is fine. First of all, congratulations on your talk. It was very beautiful because it's not only the cases or how you are solving them, but also the story behind and how hard it is to have some technologies depending where we are working. So I can relate to you because first time I listened about virtual surgical planning was in 2009, more or less. And there were, Niels Gelrich and Johan Prine and all these people who were already doing orbital trauma with navigation and these virtual things. So first, when you go to one of those courses and my feeling was, oh, this is amazing. I want to do that when I go back to my home. And then you realize that you cannot do anything because you don't have the technology available. And for us, it took 3 years to have a navigation system in my hospital. So for those 3 years, I also been exploring open source softwares, and I started with Oros, that was Osirix, and all those tools, and then I realized that there were four software tools that were really important. The segmentation, if it is automatic or semi-automatic, the better. Mirroring, free movement of STL objects, and then import and export STL objects. So whenever you can find those 4 software tools, even it is a free software or a paid software, you can then work with them. And in Spain and in Europe, we have also strict regulations. And so nowadays, everything has changed for the last 15 years, because things that were very expensive, now they are not as much as they used to be. And there are also many different external companies that can provide the service, lowering the prices. So I think that now in Europe, we have like 3 models of working. One is working totally with an external company, which in our case is easier because the hospital provides the money for each patient, and is cheaper than building a lab or doing everything in-house. Then the second model is combining, maybe doing the virtual planning in-house and then all the guides and the PSIs outside. And then the third model is building a point of care lab, as they have, for example, in Basel in Switzerland, where they can even manufacture their own PSIs. And probably that would be nice, but it requires a lot of money to build one of those centers. And also it would be not providing for one department, but for many different departments and different hospitals. So that's the situation nowadays in Europe. And that's why I'm not doing anything in-house anymore, because it's easier for us to buy it externally. But the one thing I really liked about your talk was the thing about the soft tissue components, and I think that it's not done yet. So there are many companies working on bone and predicting the bone and working with bone, but there is not software to work with soft tissue. So my question to you is, with Blender or any other open source software, have you find some tool to work with vessels and the fat tissue and all that stuff? Or do you think that it's also something that we have to work in the future?
Yeah, thank you for the comment and for your question. To answer your question, I mean, I'm not specialized in soft tissue. The first thing. But anyway, to answer it, I know that virtual planning has been used for cardiac surgery and neurosurgery a lot. So the possibility of using the virtual planning software, not just Blender, for soft tissue is, I mean, really feasible. Feasible. And in my opinion, although I'm not a specialist in engineering, I have to say that if any software, any medical or surgical software can do something, Blender can do all of them. Is the first thing. And to answer the question for the reconstruction, sometimes we use we take the angiography with contrast, and we can use the segmentation software to reconstruct the vessel for the fibula. So yeah, so I think for vascular surgery is really possible in my opinion. So and for other applications like rhinoplasty, Mr. Cicero Moraes, the author of the modified Blender that I'm using, he also have some option to design the rhinoplasty. However, I don't know anything more because I don't do rhinoplasty. But I know he has a cost. He has a training cost only a few $100s, and you can watch some video in Portuguese. Do you know Portuguese? To use Blender for the rhinoplasty. So basically, he designed a template. How high and what is the position that you want to design the nose of the patient, and then you can try to correct and you can try to correct the nasal bridge. But anyway, I don't do it, but it's the only information that I can give you.
Thank you. Thank you.
Thank you so much, Dr. Herdero. Next, I'd like to invite Dr. Chaprakit.
Hello. Congratulations, Dr. Quang, of your work. And I'm so impressed with your inspirational attempt to reduce the cost of the software in some country. For example, in Thailand, the fee of those 3D procedures still not yet is covered by insurance. So I think this is very beneficial in some situation of individual country. I have for you for two questions. In the craniofacial fracture case, sometimes a severe fracture also involve the cranial base of skull. It could be very difficult for landmark orientation of head position. Do you have any suggestions for head orientation for patient? And the next question, from my experience, those printing material will be titanium, which is still costly. The titanium is thin but strong enough to retain its shape. Can you share us for your cutting and positioning guide what kind of metal material this you use for printing?
I understand the second question, but can you repeat the first question?
Yes, it's a first question. I mean, when you use a 3D planning virtual program for the surgical planning, and we need to do a head orientation first in the virtual planning, right? And in the pan facial fracture case, some case is involve very severe fracture involve of the base of skull, and I think it's very difficult for the landmark orientation of head position. And I want to know, and do you have any suggestion for the head orientation for patient?
It's a very interesting question. I have to say, yes, the head orientation is very important Yeah, and it's especially for me because I specialize in orthodontic surgery. So when I apply the mindset of orthodontic surgery to every other field of maxillary surgery, I also think about head orientation or the natural head position that we call it. Anyway, I have to say, I doesn't really care much about the head position in the band facial trauma, but I don't say that what I'm doing is correct, because what you are suggesting is what you are suggesting, I think, is better than what I am doing. But in the case I show you in the introduction, of course, I need to at least move the teeth, the midline of the face or midline of the teeth into the true axis of the software. And then because I don't have the landmark for that case, we have, well, normally when we have the zygomatic fracture, we use a frontal bone, and we use the suture of the sphenoid bone as a landmark for the zygoma. But in that case, we don't. In that case, I didn't have that, so I try to mirror the intact side to the opposite side, and I use that as a reference for the reconstruction. Fortunately for the surgeon, we don't need absolute accuracy in doing the zygomatic fracture reconstruction. You know what I mean? Trauma fracture is not orthodontic surgery. For orthodontic surgery, we need absolute accuracy. Of course, it's not really absolute, but maybe 90% accuracy in orthodontic surgery. But in trauma case, when we reconstruct them, the zygoma, we just need some relative accuracy. However, when I do reconstruction, maybe some fibular case, I also apply the natural head position, because natural head position also give you the correct position of the maxilla, for the example, and then you can design the teeth, and you design the bone graft, and you can the teeth, and you can design the implant, and you can design the bone graft to support the implant. So to be super accurate, like what you were suggesting, if I am very keen on the orientation of the head, I will apply the natural head position for every kind of case: trauma, reconstruction, and of course, not orthodontic surgery. Yeah. I think I hope I answered your question.
Yes, thank you.
And for the second question, can you repeat the second question for me?
Yes. Can you share about your cutting and positioning guide? What kind of the metal material did you use for being?
Yeah, I use the cobalt chrome, the alloy of cobalt chrome. Yeah, the reason I use it is very simple, but of course it's also very compatible with the body. The second reason is the dental laboratory has only two options. The first one is titanium. They use titanium for the prosthodontic bar, the bar for the implant. Actually, they invested in the metal printer only for dental implant. So they gave me two options. The first one is the titanium alloy. The second one is the cobalt chrome. And I thought, I didn't leave the material inside the body, so why do I need to use titanium? So I just use the cheaper one. That's it.
Thank you.
Thank you, Dr. Chiprakit. And next, I'd like to invite Dr. Tan.
Hello, Dr. Quang, thanks for your talk. And I really think it's very difficult to do your own surgery planning. I think definitely you've shown that you put a lot of thought in all your planning and with good results. I was just wondering, I know that you use cobalt chrome cutting guides and positioning guides, but do you actually print PSIs using the software as well? in terms of the titanium specific implants?
If your question is strictly about PSI, about patient-specific implant, my answer is no, because the regulation. Because I have talked to some material provider and some medical material provider, and they saw that our regulation at this time they didn't allow. They haven't allowed us to use a 3D printed metal, 3D printed material inside the body. They only allow for some patient who agree to join the experiment, to join the study, but to do it universally, no. That's why for my own case, I have never used PSI. Yeah. But yeah,
Thank
but the
you.
positioning guide that I'm using it, I learned it from the PSI. So initially I called it the PSI, but after that to avoid misunderstanding, I changed the name to positioning guide.
I see. So now you're still using a combination of wafer for the occlusion as well as your cobalt chrome guides, right? And I was just wondering, have you ever had to abandon your guides, your cutting guides or your positioning guides? Have you ever had experiences where they don't fit and you had to, not use them?
For orthodontic surgery, initially I was really confident with the guide. The reason I was confident is because I trusted the papers that I read. But they now because if we use if we do the maxilla first in the traditional way, we need to record the CR, the centric relation, very accurately. However, sometimes it's not really possible. So we have to do either mandible first or using PSI. Initially, in some of my first case, I use PSI. I use only PSI and with the final splint only. And at that time I was really confident. However, when I reviewed my case, I took the CT scan after I took the CT scan and I realized that it was not accurate, even if the PSI. So, and at the beginning, I didn't understand the reason. And after that, I understand, after that, I found the reason. Okay, it's another story. It's another long story if you are really interested. Anyway, after that, I'm using both the traditional splint and the PSI. And even more, I use the splint for mandible first with the PSI. So when I do orthodontic surgery, I do the mandible first. I do the mandible first with the splint, and after that, I do the maxilla, and I put the maxilla into the new mandible with the final splint, and after that, I insert the PSI as a positioning guide to the maxilla, and I fix it. So I use two measures to make sure that to improve the accuracy.
Thank you for your answer. Yes, I do understand the issues about having to make sure that the mandible is in a centric relation when you're taking your records.
Sorry. I haven't. Sorry, I forgot the initial question. I forgot it. Yes, of course. Sometimes I have to abandon it. So and because I use two methods. The splint, the traditional splint, traditional wafer, and the PSI. And if I found that the PSI is not fit, I just throw it away. And use the splint. Okay.
Thank you.
Sorry for the interruption.
No worries. Thank you for sharing. And I can see a few things that could go wrong if you are doing the mandible first and you were just using a splint to position the mandible first, and then using your PSI together with your final wafer for the maxilla. I mean, there will be inherent issues with that. Because a lot of things can be different when you're doing the mandible first with the rotation how you rotate the mandible, and there are many factors that come into play, whether you derotate it and then you get it into the final position again. And I think these little things could be some reasons why sometimes your positioning guide may not fit, because we can't really control how we rotate the mandible on the software, on any software that we use, whether is it the Blender software or even the ProPlan software. And the condyle and the rotation of it is definitely something that we cannot fully control. But definitely great work. I just have one last question, and maybe not really regarding the planning, the 3D planning itself, but because I do a lot of obstructive sleep apnea cases myself, and I have also had attachment at Stanford University previously with Dr. Stanley. But I was wondering, when you did your segmental case for the mandible, did you take into account the geniotubical position when you were planning? Do you take into account the geniotubical when you were planning your anterior segmental as well as the genioplasty?
Actually, I have to say that Dr. Stanley Liu, Professor Stanley Liu came here last month. Before that, I didn't have any other of the sleep apnea case. So of course I know about it because I learned it from the textbook, and my professor did a lot of sleep apnea. So I did some in my training, but for my own, it was my first case. So since Dr. Stanley Liu came here, so I accepted sleep apnea case, and for that case actually I discussed with Professor Stanley Liu, and he also asked me the same question as you are asking, that do I take into account the tubercle? So for me, in that case, it's not really a problem, but because luckily the tubercle of that patient was very low, and it's lower than my subapical cut. So there's no problem with the tubercle or the insertion of the muscle. Yeah. So I have to answer your question. Yes, I really think about the tubercle.
Thank you very much.
Thank you, Dr. Tan. And thank you once again to all the panelists for your comments. But we should move on to Q&A. However, due to the time restraint, I think we will again collect the questions, and then we'll ask Dr. Quang to answer it for us at a later time, and then we'll post it on our Facebook group. So would that be okay with you, Dr. Quang?
Sorry, say it again, please.
Would it be okay if we collect the Q&A questions that the audience have for you in the chat? Yeah. And then send it to you later on to have you answer them, and then, and then we'll post your answers on our Facebook group.
Yes, you are more than welcome, and I want to share my screen again. So I have my email. Yeah, you can do it through Facebook. Yeah, I'm very happy, because if you asking me a lot of questions, it means you really care about my presentation. I'm very happy about that. And secondly, I have my WhatsApp number and my email here. You can contact me directly if you want, if it's more convenient for you. Okay, thank you a lot.
And then, so I'll ask Professor to take over.
Yes, thank you, Junior. And thank you, Dr. Quang, for your very excellent providing the 4 very interesting cases to share, and we can learn a lot from your cases. Especially, I have to explain the policy from Taiwan that's much different from your policy in Vietnam. In Taiwan, even the surgical guide, it could not be performed intraoperatively, and we could not print it by ourselves, because from our IRB in Taiwan, it's very strictly and cannot guarantee anything. Maybe from the 3D printer, even the metal or non-metal one is allowed. Maybe it probably will give some chemical change. So I know you guys are very smart, and you can change, because it's very relatively cheap, and because it's not implant. It's just only to guide you to put the implant inside the maxilla or the mandible. So we are still concerned about the biocompatibility and the bioactivity. Yes, So, but you using the blender, my son used blender for his homework as well. So you are very smart in your blender in designing the surgical guide and then replace with the implant inside your fixations. So this is the first comment from my side. The second one is according to mandible first. Yeah, I have the same question like the Dr. Tan from Singapore. Depending on the maxillary first or mandible first, I think the PSI or your surgical guide is much maybe accurate in the maxillary first cases, because the ones we do the osteotomize the maxilla and you can put the surgical guide and you can fix, maybe can get a higher accuracy with the right position. Somehow as we do the mandible first, we have some might be the facial asymmetry cases. We have to do a lot of yaw rotation or roll rotation. The mandible condyle is not so reliable. They could change the real mandible's reposition site, and that will induce the further your maxillary reposition is different, maybe cannot fit very well according to your PSI. So it's one of my concern too as well. So anyway, we are really so happy and to learn a lot from you today's talk. Yeah, thank you very much, Dr. Guan. And especially to thank you for all our 4 very excellent panelists. We are all come from all different countries, especially today. Our 4 panelists are all not men. You guys are all very excellent female doctors. So one is from our centers, Professor Ellen Go and Professor Susana Heredero from Spain, and Dr. Narissa Bong, my old friend, and Dr. Tan Mei Hui from the Zhangyi General Hospital, Singapore. At last, I probably need to advance promote our 2 programs in Chang'an in the end of this in this year. So please allow me to share my screen for 2 minutes. The first one, just like share my screen, Chang'an Forum 2024, the date is around the 28th to 30th of this October. As usual, our mentor, Professor Yurei Chen, Professor Chen Chong Chen, and Professor Daniel Wang will give us their very experienced lectures in our Chang'an Forum. And maybe you can scan the QR code, and we all very excited to invite all your participation in these programs. This is one of I want to advertise here. The second one is our cadaveric dissection course in Chang'an Memorial Hospital. We delivered 2 hand-on courses. The first one is the endoscopic knee facelift, and the second one is the endoscopic zygoma and the mandible reduction surgery. And the date is in November too. So once you have interested in these 2 programs, please scan the QR code as well. Okay. I hope to invite all of you to show your screen. This is a very important time to have the group photos every time. So, my friend, could you open your screen? And I will count to 3, and please give me a big smile, no matter you are in the daytime or nighttime. Thank you so much for your come for this webinar. Hello, my friend. Thank you for your join. Okay, I will count to 3. Smile, smile, smile. 1, 2, cheese. Thank you so much. Okay. Thank you, my friend, and thank you, Dr. Guan, again. And our next ICC webinar will located in September, and we will keep you posted in our Facebook. And hopefully you can looking forward to your participant in the next webinar. Thank you very much. Have a good day and have a good night. Bye-bye.
Thank you, everyone.
Thank you. Thank you, Professor Go. Thank you, Dr. Mei Hui Tan. Thank you, Dr. Jia. Thank you, Susanna. Bye.
Thank you.
Thank you so much. Thank you, Dr. Guan.
Thank you. See you later. Bye.
Yeah, hopefully to see you soon in person.
I hope it
谢
too.
谢。Thank you, thank you. 好，谢谢 Junior。
Yeah, Sean, bye bye. Have fun.
那他这个问题是不是要叫他再写一写，然后再回给我们？需要吗？
对啊，对啊，我是这样想，然后
好好，
我刚才已经把它那个就是储存下来，然后我寄，
寄给他。好
诶，
好好好，OK。
那我寄给他好了。OK OK
好好，你再寄给他，然后不然你就群主 CC 我，然后我再跟他要。Yeah，OK，
OK，好啊好啊，
好
没问题。
，OK，好，Have a good one，拜拜拜
OK，
拜
拜拜拜
拜
拜。
拜。